Hey, how's it going, everyone? This is FixerMed. Welcome back to my high yield biochemistry review series for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. This will be part 16 of my multi part video series covering the entire discipline of biochemistry from start to finish in a high yield but comprehensive manner. So, without further ado, let's go ahead and get started on today's content. Today, we'll be covering all of the high yield vitamins you should know for these examinations. Now, fair warning, you need to know a lot about these vitamins, and there are a lot of vitamins. So let's get started on the first vitamin. We have vitamin A, also known as retinol, retinal, and retinoic acid. This transcription factor binds to the retinoic acid receptor. Topical tretinoin is the primary treatment for acne as it suppresses sebum production. Oral isotretinoin, a potent form of vitamin A, is a last resort option for acne treatment due to its high effectiveness. However, it is teratogenic, necessitating a beta HCG test before initiation. If asked about vitamin A associated teratogenicity on the USMLE, cleft lip palate is usually the correct choice. Topical tretinoin, while not teratogenic, can cause desquamation and photosensitivity. Vitamin A is vital for night vision, skin health, and immune function. Its deficiency may result in nyctalopia, squamous metaplasia, and immunodeficiency. Nyctalopia is basically night blindness, by the way. And deficiency is rare due to its fat-soluble nature and storage in significant amounts in the liver's LTO cells. Fat-soluble vitamins include A, D, E, and K, remembered as all dogs eat kittens. Please be sure to remember that mnemonic. If not, I'll be sure to list out all the mnemonics from this review series in a separate video. Malabsorptive disorders such as cystic fibrosis, celiac disease, and Crohn's disease can cause deficiency. Excessive vitamin A intake leads to complications like cerebral edema with pseudotumor cerebri, increased intracranial pressure, papilloedema, confusion, teratogenic effects, hepatotoxicity, and dyslipidemia. Notably, toxicity can result from the consumption of bear liver. Moving on. Next vitamin we have is vitamin B1, which is also known as thiamine. Thiamine is crucial for dehydrogenase reactions, plays a vital role in 4 key enzymes tested on the USMLE. Pyruvate dehydrogenase converts pyruvate to acetyl-CoA. Alpha-ketoglutarate dehydrogenase facilitates the transformation of alpha-ketoglutarate to succinyl-CoA in the TCA cycle. Branch-chain keto acid dehydrogenase is associated with maple syrup urine disease, involving the inability to metabolize leucine, isoleucine, and valine. And trans-ketolase is produced in the pentose phosphate pathway, known as the HMP shunt. A deficiency in thiamine, often observed in alcoholics, gives rise to Wernicke-Korsakoff syndrome, impacting the mammillary bodies and resulting in Wernicke encephalopathy, characterized by ataxia, confusion, ophthalmoplegia, and Wernicke. In emergency situations with unconscious patients, thiamine B1 administration with glucose is crucial to prevent anterograde amnesia. Korsakoff psychosis is marked by confabulation due to retrograde amnesia. Dry beriberi manifests as neuropathy, while vet beriberi presents as dilated cardiomyopathy. Let's move on to the next vitamin. Next, we have vitamin B2, also known as riboflavin. This vitamin is utilized as a cofactor in FAD-FMN reactions. This essential vitamin is necessary for the conversion of succinate to fumarate in the TCA cycle, involving the transformation of FAD to FADH2. B2 and B6 serve as cofactors in the synthesis of B3. A deficiency in this vitamin leads to erybroflavinosis, with angular cheilitis being a nonspecific manifestation. Next, we have vitamin B3, which is also known as niacin. It is utilized in NAD plus NADH reactions. This essential vitamin, known as B3, is crucial for various physiological processes. In cardiovascular effects, it positively influences HDL levels and reduces VLDL export by the liver. Tryptophan, a precursor to niacin synthesis, may be affected in Hartnup disease, leading to niacin deficiency due to decreased reabsorption in the proximal convoluted tubule (PCT) of the kidney. Additionally, tryptophan, a precursor to serotonin, can be depleted in carcinoid syndrome, contributing to niacin deficiency in certain cases. A deficiency in B3 results in pellagra, characterized by dementia, dermatitis, and diarrhea. Delirium, often associated with underlying dementia, can be a presentation as well. Dermatitis may manifest as castle necklace, hyperpigmentation of forearms, or blistering. Excessive B3 intake can lead to hyperinsulinemia, hyperuricemia, known as gout, and flushing. Flushing, attributed to prostaglandin rather than histamine, can be prevented or mitigated with aspirin/NSAID. In cases where cardiovascular history and podagra, gout of the big toe, are present, niacin might be contraindicated as it can exacerbate gout symptoms. Let's move on to the next set of vitamins we need to know. Next, we have vitamin B5, which is also known as pantothenate or pantothenic acid. It is a precursor to coenzyme A, which is transferred to pyruvate to form acetyl-CoA. It is essential in cellular metabolism. A deficiency in this compound is associated with the manifestation of burning feet syndrome. Next, we have vitamin B6, also known as pyridoxine, pyridoxal, and phosphate. This crucial vitamin is involved in decarboxylase reactions, playing a fundamental role in the conversion of various substrates. For instance, it catalyzes the transformation of L-dopa to dopamine via L-dopa decarboxylase, converts glutamic acid to GABA through glutamic acid decarboxylase, and facilitates the conversion of histidine to histamine via histidine decarboxylase. Additionally, it participates in transaminase reactions, such as the conversion of pyruvate and glutamate to alpha-ketoglutarate and alanine with the assistance of B6 and ALT, as well as the transformation of oxaloacetate and glutamate to alpha-ketoglutarate and aspartate through B6 and AST. This vitamin is also indispensable in the initial step of heme synthesis, where succinyl-CoA and glycine in conjunction with B6 and D-alanine synthase or D-ala synthase generates sigma amino levulinic acid. Actually, I think that's gamma amino levulinic acid, D-ala, highlighted as highly significant in step 1 NBMEs. This vitamin is further crucial for synthesizing cysteine from homocysteine. Notably, deficiency can arise due to isoniazid, a medication for tuberculosis, resulting in peripheral neuropathy and in some cases seizures. Let's move on to the next set of vitamins. Next, we have vitamin B7, which is also known as biotin. This essential vitamin plays a crucial role in carboxylase reactions, influencing various metabolic pathways. Pyruvate carboxylase, a gluconeogenic enzyme, facilitates the conversion of pyruvate to oxaloacetate, OAA, a crucial step for reversing glycolysis. To move from pyruvate to phosphoenol pyruvate, pyruvate is initially converted to oxaloacetate by pyruvate carboxylase, and subsequently oxaloacetate is transformed to PEP, phosphoenol pyruvate, via PEP carboxykinase. This phosphoenol pyruvate can then contribute to gluconeogenesis. Acetyl-CoA carboxylase is involved in the first step of fatty acid synthesis, converting acetyl-CoA to malonyl-CoA. Malonyl-CoA not only participates in further reactions for fatty acid assembly, but also inhibits fatty acid breakdown by blocking the carnitine shuttle, preventing fatty acids from moving to mitochondria for beta oxidation. Propional-CoA carboxylase is crucial in odd-chain fatty acid breakdown, where odd-chain fatty acids release a terminal 3-carbon unit called propional-CoA. After conversion to methyl-malonyl-CoA, the latter is further metabolized to succinyl-CoA in the TCA cycle using vitamin B12. Deficiency of this vitamin can result from consuming raw egg whites, which contain avidin that binds to the vitamin and hinders its function. Let's go ahead and move on to the next set of vitamins. Next, we have vitamin B9, which is also known as folate and folic acid. Vitamin B9 is involved in a multitude of intricate reactions alongside vitamin B12. Folate assumes various forms, including tetrahydrofolate, 5-methyl tetrahydrofolate, and 5,10-methylene tetrahydrofolate. Thymidylate synthase catalyzes the conversion of uracil, DUMP, and 5,10-methylene tetrahydrofolate to thymine, DTMP, and THF, a process inhibited by 5-fluorouracil. Furthermore, homocysteine in conjunction with 5-methyl tetrahydrofolate and vitamin B12 is transformed into methionine and THF. Subsequently, methionine undergoes phosphorylation by ATP to produce S-adenosylmethionine, SAM, a universal methyl donor crucial in various nucleic acid, protein, and lipid reactions. Vitamin B9, found abundantly in dark green leafy vegetables, is essential for preventing megaloblastic anemia and hypersegmented neutrophils. Its deficiency is linked to neural tube defects, particularly critical during the first 3 to 4 weeks of gestation. Anti-epileptic medications, such as valproic acid, phenytoin, and carbamazepine, can induce B9 deficiency, as indicated by hypersegmented neutrophils in imaging. B9 deficiency is characterized by an increase in homocysteine levels, while methylmalonyl-CoA or methylmalonic acid remains unchanged, distinguishing it from B12 deficiency, where both homocysteine and methylmalonic acid levels are elevated. Let's go ahead and move on to the next set of vitamins. Moving on, vitamin B12 is also known as cyanocobalamin. Vitamin B12 is intricately involved in an array of complex reactions alongside B9. It is crucial for several metabolic pathways. It is a vital cofactor for methionine synthase, enabling the conversion of homocysteine and 5-methyl tetrahydrofolate into methionine and tetrahydrofolate, a process essential for methionine synthesis, an indispensable amino acid. B12 also plays a pivotal role in regenerating the tetrahydrofolate form of B9, participating in the intricate series of reactions involving homocysteine, 5-methyl tetrahydrofolate, B12, and methionine, ultimately producing S-adenosylmethionine, known as SAM, a universal methyl group donor. SAM is utilized in numerous nucleic acid reactions, and after donating a methyl group, it facilitates the regeneration of homocysteine. Furthermore, B12 is necessary for methylmalonyl-CoA mutase, an enzyme critical in odd-chain fatty acid breakdown. Deficiency in B12 leads to megaloblastic anemia and hypersegmented neutrophils, akin to B9 deficiency. It uniquely contributes to subacute combined degeneration, a neuropathy characterized by demyelination of specific tracts in the spinal cord. Elevated levels of homocysteine and methylmalonyl-CoA or methylmalonic acid differentiate B12 deficiency from B9 deficiency. Causes include loss of parietal cells, terminal ileum resection, absorptive disorders affecting the terminal ileum, veganism, and infection with Diphyllobothrium latum. The Schilling test is a diagnostic tool for identifying the root cause of B12 deficiency. Let's move on to the next set of vitamins. So next up we have vitamin D, which is crucial for calcium homeostasis and bone calcification. Vitamin D synthesis initiates in the stratum basale of the epidermis from 7-dehydrocholesterol. The conversion of 7-dehydrocholesterol to cholecalciferol occurs through the UV beta radiation exposure. If sunlight deprivation is indicated, deficiency of cholecalciferol is likely, as individuals still synthesize 7-dehydrocholesterol without sunlight exposure. Cholecalciferol undergoes hydroxylation in the liver to produce 25-OH-D3, known as calcidiol. Hepatic hydroxylation may decrease in alcoholics. Subsequently, calcidiol reaches the proximal convoluted tubule of the kidney, where parathyroid hormone upregulates 1-alpha hydroxylase, converting it into its active form, 125-OH-2-D3, calcitriol. Calcitriol promotes the absorption of calcium and phosphate in the small bowel and facilitates the conversion of unmineralized osteoid into mineralized hydroxyapatite in bones. Vitamin D deficiency results in rickets in children and osteomalacia in adults, often associated with malabsorptive disorders like cystic fibrosis, celiac disease, or Crohn's disease. Hypovitaminosis D is characterized by decreased calcium phosphate and an elevated parathyroid hormone level. In contrast, hypervitaminosis D, often seen in sarcoidosis, leads to increased calcium and phosphate absorption, suppressing PTH levels. In Williams syndrome, an autosomal dominant disorder involving chromosome 7, individuals exhibit elfin-like facies, supravalvular aortic stenosis, and hypercalcemia due to heightened sensitivity to vitamin D. Move on to the next set of vitamins. Next we have vitamin C, which is also known as ascorbic acid. Vitamin C is integral to hydroxylase reactions, is indispensable in critical biological processes. It plays a vital role in collagen synthesis, facilitating the hydroxylation of proline and lysine residues crucial for the structural integrity of connective tissues. Additionally, vitamin C serves as a cofactor in norepinephrine synthesis, aiding in the conversion of dopamine to norepinephrine through the enzyme dopamine beta hydroxylase. Beyond its involvement in neurotransmitter synthesis, this vitamin is essential for immune function. Moreover, vitamin C is required for iron absorption in the duodenum, acting as a ferri reductase. A deficiency in vitamin C results in scurvy, characterized by manifestations such as bleeding gums, perifollicular hemorrhages, and an overall ill appearance. Conversely, an excess of vitamin C intake can lead to the formation of calcium oxalate stones. Vitamin E. Vitamin E is also known as tocopherol or tocotrienol. Functioning as a free radical scavenger, this vitamin integrates into the cell membranes, actively donating hydrogen atoms to neutralize free radicals and mitigate oxidative damage. While deficiency in this vitamin is rare, its association with neuropathy mirrors the subacute combined degeneration observed in vitamin B12 deficiency. In USMLE scenarios presenting neuropathic symptoms without listing B12 as an option, choosing this vitamin as a deficiency is imperative. Conversely, an excess of this vitamin can antagonize the effects of aspirin, warfarin, and various chemotherapeutic agents, emphasizing the importance of maintaining a balanced intake to avoid potential interactions with these medications. Let's move on to the next set of vitamins. Next, we have vitamin K. Vitamin K serves as a crucial cofactor for the enzyme gamma-glutamyl carboxylase. Vitamin K plays a pivotal role in the activation of clotting factors 2, 7, 9, and 10, along with the anti-clotting proteins C and S, primarily within the liver. It is essential to distinguish gamma-glutamyl carboxylase from vitamin K epoxide reductase, as the latter is targeted by warfarin, while vitamin K acts as a cofactor for the former. Vitamin K epoxide reductase's role is to recycle vitamin K to its active form. Deficiency in vitamin K can manifest in two distinct scenarios on the USMLE. Neonates may exhibit bleeding from the umbilical stump due to a lack of synthesized vitamin K in the sterile bowel, addressed by a vitamin K injection. In older patients on broad-spectrum antibiotics for over 6 weeks may experience deficiency due to gut flora obliteration. Furthermore, vitamin K serves as a slow reversal agent for warfarin, crucial in scenarios where patients are actively bleeding or require surgery, although fresh frozen plasma remains the preferred intervention in such cases. Let's move on to the next set of vitamins. Next, we have copper. Copper serves as an essential cofactor for lysyl oxidase. This element plays a crucial role in the catalysis of cross-linking processes in newly synthesized collagen and elastin. Excessive levels of this cofactor are associated with Wilson disease, an autosomal recessive disorder linked to chromosome 13. In individuals with Wilson disease, there is an inability to effectively secrete copper in the bile, resulting in increased copper levels in urine and decreased serum ceruloplasmin. The condition presents with various manifestations, including hemolytic anemia, cirrhosis, Parkinsonism, due to copper deposition in the basal ganglia, and Kayser-Fleischer rings, characterized by copper deposition in descendant membrane of the cornea. Treatment for Wilson disease typically involves the use of penicillamine, a copper chelator. On the contrary, deficiency of this cofactor is observed in Menkes disease, an X-linked recessive disorder. Menkes disease is characterized by an impaired ability to absorb copper in the duodenum, leading to distinctive features such as wiry or springy hair. Selenium. Selenium is an indispensable coenzyme for glutathione peroxidase, supporting the reaction where two molecules of reduced glutathione 2GSH react with hydrogen peroxide, yielding oxidized glutathione disulfide, GSSG, and two molecules of water. Let's move on to the next set of vitamins. Next, we have iron, which is utilized in the synthesis of hemoglobin. Iron holds a crucial role in various physiological processes. Excessive iron levels are notably observed in hereditary hemochromatosis, an autosomal recessive disorder linked to chromosome 6. In hereditary hemochromatosis, there is an aberrant increase in duodenal iron absorption, leading to an inability to regulate absorption effectively. This condition manifests as bronze diabetes, characterized by hyperpigmentation due to hemosiderin accumulation, diabetes resulting from iron deposition in the pancreas's tail, and diverse symptoms such as arthritis, pseudogout, infertility, and cardiomyopathy. The recommended treatment for hereditary hemochromatosis involves serial phlebotomy, as chelators are not suitable in this context. Chelating agents such as deferroxamine or deferrocerox find application in transfusional siderosis, a form of secondary hemochromatosis arising from chronic blood transfusions. Zinc. Zinc is deployed within zinc finger domains, integral components of certain transcription factors involved in DNA binding. Zinc is abundantly present in semen. Insufficient levels of zinc result in a deficiency that manifests with symptoms such as anosmia, hypogeusia, alopecia, and diarrhea. A specific genetic condition linked to the zinc deficiency is acrodermatitis enteropathica, an autosomal recessive disorder characterized by the jejunum's inability to absorb zinc, leading to the presentation of dermatitis. All right, guys, that is all for the vitamins we'll cover in this video for now. NBME application-based reasoning will be done in a separate video because this was a super long video, and I know a lot of you guys are probably checked out by now, but I want to let you know the vitamins are super high yield. They show up in nearly every organ block, so please go ahead and memorize them now to make your life easier. That's why I made such a long, boring video, but you have to know this material. So, as I said, we'll do the questions in part 16b. Video is probably way too long. It is. Take a mental break, compartmentalize all the content, and then hit the questions in the next video. You got this. Stay strong. It's hard to retain all this, but we will get through this together. Guys, I hope you have a great day. And if you have any questions, comments, or concerns, please feel free to put them in the comment section below. If not, this is FixerMed signing off, and I'm gonna go take a break from talking and catch my breath because I've been just reading for the past 30 minutes. So take care, guys, and goodbye.